welcome to everyone. Good afternoon. Alors, tout d'abord, encore une fois, un grand merci à vous tous, à vos équipes, à tout le monde qui est au travail dans des conditions pas toujours faciles. Merci d'être là. And also, thanks for your collaboration, for everything you're doing for our patients and their families. The numbers look good. Dr. Frenette will go over them. Je pense qu'il y a moyen d'être optimiste à ce moment-ci. Alors, mais il y a encore quelques semaines, peut-être quelques mois encore vraiment difficiles. Puis par la suite, on a bon espoir que les choses vont s'améliorer de façon marquée. Alors, l'ordre du jour d'aujourd'hui, la diapo, s'il vous plaît. Parfait, ce serait le deuxième diapo, s'il vous plaît, Evelyne. Alors, un mot rapide sur la vaccination, puis aussi sur la journée de la vérité et de la réconciliation qui a eu lieu hier. After that, Dr. Frenette will give us his usual update on the pandemic. And he's crunched the latest numbers. And so we're really eager to hear what he has to tell us. Puis ensuite, une présentation qui est très importante sur la vaccination des membres du personnel. And I know that you will have a lot of questions. So we've kept a lot of time for question and answers. Et ça sera animé par le Dr. Robert Barnes, notre DSP aux Children. Prochaine diapo, s'il vous plaît. Alors, il y a quand même des choses très encourageantes qui se passent au CUSM en ce qui concerne la vaccination. Si vous voyez les chiffres, en une semaine, on a presque 600 personnes qui ont décidé de recevoir une première dose. Alors, je suis très satisfait de ça. Et c'est normal qu'il y ait moins de personnes qui reçoivent une deuxième dose seulement maintenant parce que la plupart des gens qui avaient reçu déjà une dose avaient reçu leur deuxième dose. But of course, that will follow. The second dose will follow later for the people who just got their first dose. So that's very encouraging. Alors, il est probable que la plupart des personnes qui nous écoutent sont doublement vaccinées déjà. Donc, je vous demanderai de parler à vos équipes. Talk to your staff, talk to your people, tell them how important it is. You'll see the data that Dr. Frenette will be presenting. I think it's these data, they speak by themselves. Alors, sur l'importance de la vaccination, sur le degré de protection que ça donne aussi. Prochaine diapo. Merci. So September 30th was the National Day for Truth and Reconciliation. On this occasion, we decided that we would publish the fact that the MUHC, during its board meeting that occurred on the 20th of September, adopted Joyce's principle. So Joyce's principle aims to guarantee to all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. Joyce's principle requires a recognition and respect of Indigenous people's traditional and living knowledge in all aspects of health. And the source for this formulation of Joyce's principle is a council of the Atikamekw de Manawan and the Atikamekw Nation Council. Je pense qu'il est important de dire que même si le principe de Joyce s'adresse aux Autochtones, bien entendu, pour le CUSM, ça touche l'ensemble des personnes qui reçoivent des services chez nous. Peu importe leur race, leur couleur, la langue qu'ils parlent, leur religion, leur croyance, leur orientation sexuelle. Donc, pour nous, c'est vraiment le principe de Joyce, c'est vraiment, ça va beaucoup plus large que ce qui est dans le texte qui est là, dans notre idée, dans notre pensée. Vraiment, on veut vraiment être le plus inclusif possible, le plus équitable et puis le plus diversifié possible. Je pense que le CUSM est déjà en tête de file dans le réseau québécois, mais par l'adoption du principe de Joyce, lors de cette réunion du conseil d'administration le 20 septembre dernier, on envoie un message très, très fort à l'effet qu'on veut continuer à être les leaders et qu'on veut aussi poser des gestes, pas seulement des paroles. Le comité CAID, le comité pour d'action sur l'inclusion, diversité et l'équité. They came up with about 10 recommendations. These are preliminary recommendations that were presented to the board last week, 10 days ago. So we're already looking at ways to implement most of these recommendations. We still have discussions on one or two of these recommendations, but otherwise we're moving forward. So I would like to thank the members of the CA committee for the great work they've done over the last year. I know some people thought it was slow coming, but of course, at the same time, we had to deal with the pandemic. Everyone was busy doing something else. So I think they did a fantastic job, and I would like to thank them. Alors, un grand merci aux personnes qui ont travaillé sur les recommandations du comité d'action sur l'équité, diversité et inclusion, puis on travaille déjà pour l'implantation de ces recommandations-là. Alors, sans plus tarder, je vais laisser la parole au docteur Frenette qui va nous faire sa présentation usuelle. Alors, on est suspendu à ses lèvres comme d'habitude. Charles, c'est à vous.
Merci beaucoup. Bon après-midi à tous. Diapo suivante, s'il vous plaît. Merci. Alors, je ne sais pas si vous avez l'impression de vivre des montagnes russes, mais en effet, on passe par toute la gamme des émotions avec ce petit virus qui se promène à droite et à gauche. Diapo suivante. But the name of the game is still to stay in front of the wave. And I'll try to show you that we're not doing too bad. Next slide. I haven't shown you this before, but if you look at the world situation, you can see that the fourth wave is on its way down in a number of continents, certainly in Asia, Europe. North America still has quite a few cases. But you can, I don't know if you remember, our big wave was wave 1, and how much for the rest of the world, the second, third, and fourth wave was much more preponderant. Next slide. If we go by country, however, we see there's quite a different pictures. And as much as Canada is along with Russia, France, and the European countries down here, even India has gone back down. There's a few countries that are interesting, and one of them is Israel, which, remember, was the leader in vaccination, and they went through a very large outbreak just early September. And, you know, they were the first one to vaccinate, so people we're wondering, you know, is this vaccine failure or not? Turns out that there are a combination of factors, but certainly, despite vaccinating everyone earlier, they had a good substantial proportion of the population that was not vaccinated for religious belief. That's one thing. The second thing is they followed the 21-day interval between the two doses. And we now know that this 21-day interval is probably suboptimal in terms of vaccine response. But it is nice to see they've gone on to give a third dose and upgrade their vaccination status. And it's nice to see that it's been coming down in the last week. Next slide. Down to Canada. As you know, that we were the first one hit hard. This time, fourth wave is hitting hard, really out west Canada. You've heard the stories in Alberta. They're basically doing what we did in the first wave, shutting down all elective surgeries. Their ICUs are full. And their rates of infection for the last week is 5 to 6 times our rate. And as you can see, they really have not peaked as of yet in Alberta. Next slide. In Quebec, our numbers of roughly oscillating between 600 and 700 per day. And you can see our curve. This is wave 3, wave 4, sorry, wave 2, wave 3, wave 4. And the nice sign is you can see is we seem to have reached a plateau and even a slight decrease. The moving 7-day average has gone down a little bit, which is quite interesting. Yet this fourth wave was associated with an increase in mortality in the month of September as well. Next slide. Where are the cases actually in Quebec? Well, a good third, if not 40% of cases are in Montreal. But if we take, the Laval region and the Montérégie region, altogether, the greater Montreal accounts for about 2/3 of cases. Per 100,000 population, Laval is still a region that has had the highest rate for quite a while, and Montreal is second, along with Chaudière-Appalaches. Next slide. If we look then at the Montreal region, here you have on the top graph the number of cases per week. And the bottom graph in color is the source of acquisition. And if you remember the last webinar, I was telling you that the greatest source in July, early August were travel. This source has gradually decreased and paved the way to really familial contacts as the main source of acquisition. However, I want you to look at the orange that is growing, and the orange is what milieu d'enseignement, école, cégep, université. So as expected, a greater proportion of cases are now related to school at all levels. Next slide. What age group is hit currently? Well, if you followed what I just told you, about 40% of cases are in children less than 19 years old, not unexpected. And the second age group is 30% in the 20 to 39 age group. Next slide. If we look now at hospitalization, this is probably, to me, the most important slide of the presentation, if you weren't aware. Roughly, we have about 310 people hospitalized, a third of which are in ICU, so a greater proportion of people in ICU. But if we look at current hospitalization in terms of vaccine status, you can see that close to 80% of hospitalization are in people either non-vaccinated or incompletely vaccinated. 88% of ICU cases are either unvaccinated or partially vaccinated. And 90% of people ventilated, intubated, are either non-vaccinated or partially vaccinated. So this really is an outbreak in hospitals of the non-vaccinated population. And I think if everyone knew this, there might be a little bit less resistance to vaccination. If we look at the relative risk in people who are not vaccinated, to get the infection is 7 to 8 times, to be in a hospital is 25 to 33 times, and to go in ICU is like 44 to 50 times higher. So this defies any statistical analysis for significance because it's highly significant. Next slide. Current outbreaks in Montreal, and this unfortunately with the fourth wave. Last time it was the island was relatively clear, and so you can see now that we have over 100 outbreaks in Montreal. I think close to 180 as of this morning. Of course, schools are the major ones. Work milieu, the second one. However, we are seeing some cases now, outbreaks in healthcare milieu. In fact, in Montreal, currently there are 19 outbreaks, 5 in acute care hospitals, 6 in CHSLD, and 2 in RPA. So unfortunately, we're not out of the woods. Next slide. This is the MUHC. This graph I took a couple days ago. We've been hovering around 20 patients for the last couple of weeks, of which half are in ICU. Next slide. This morning, you can see with 17 active plus 4 recovered, so 21 patients, 9 of which were in ICU, including 1 at the children and 8 at the VIC. Next slide. From a laboratory point of view, our lab is still performing extremely a lot of tests. You can see a decrease in volume here, which corresponds to when we closed to the public, to the general public. We're still doing our patients, our healthcare workers, but the positivity rate in the last 2 weeks is around 3%, which and in Montreal, it's been going down slowly. Next slide. My favorite graph, healthcare workers, the one I care the most about. Since by the way, the 4th wave's official start is the 19th of July. And since the 19th of July, we've had about 80 healthcare workers testing positive. And you can see that 90% of them were community acquired. We've had 1 small outbreak in the housekeeping department that implicated 6 workers, 3 of which were not vaccinated. Next slide. If we look at this 4th wave in healthcare workers, roughly speaking, about half of the cases we see are in vaccinated healthcare workers, and about half in non-vaccinated healthcare workers. So remember, the vaccine is not 100% positive, effective. We say around 90%. And so you may look at this graph and think, well, you know, half the people are not vaccinated, but the fact is 90% of people are vaccinated. And so it's normal that we have some cases in that population. Here, only 10% of people are not vaccinated at the MUHC, yet they account for 50% of all cases in our healthcare workers. Next slide. So what's new? So we're all asking ourselves, how good is the vaccine? I showed you some evidence just in the last slide that we still have cases. This is a study that came out from INSPQ. In fact, it came out on Wednesday. Je vais la présenter en français. Il y a 3 informations. La première information, c'est quel est le meilleur intervalle entre les doses de vaccin. Et vous voyez ici l'efficacité vaccinale quand le vaccin est donné 3 à 4 semaines entre les 2 doses, 5 à 6, 9 à 11, 12 à 15 et plus de 16 semaines. Et ce que vous pouvez voir, c'est qu'avec probablement tous les vaccins, plus avec le AstraZeneca, plus l'intervalle est grand, meilleure est l'efficacité vaccinale. Et c'est ce que je vous disais un peu plus tôt, ça peut peut-être expliquer pourquoi Israël, qui a pris le 21 jours, a eu plus de cas chez des personnes vaccinées et qu'au Québec, on a été chanceux parce qu'on semble avoir choisi l'intervalle qui est le plus efficace. Deuxième question. Est-ce que l'immunité dure avec le temps? Alors, cette étude-là a été faite chez des adultes en haut de 60 ans qui vivent en communauté. On ne parle pas de CHSLD ou de résidence pour personnes âgées. Et on peut voir que jusqu'à 5 mois après la 2e dose, l'immunité semble se préserver quand même de l'ordre de 85 à 90%. Certainement, ça préserve contre les hospitalisations. C'est sûr que c'est un suivi qui est encore très court parce que la 2e dose, on l'a donnée seulement au mois d'avril-mai. juin chez la plupart des cas, mais l'immunité de la vaccination induite par la vaccination semble être préservée. Troisième information, est-ce qu'il y a des différences entre les vaccins? Et vous avez ici cette immunité-là ventilée selon les différents vaccins. Et ce qu'on peut voir, et il y a 4 objectifs. Si on regarde pour les infections, toute infection c'est en bleu, le delta en rouge vin, les hospitalisations en orange et le delta hospitalisation en jaune. Qu'est-ce qu'on voit? Ben, on voit que, en effet, on semble avoir une meilleure efficacité vaccinale avec le Pfizer et le Moderna et un peu moins avec le AstraZeneca contre toutes les infections. Par contre, si on regarde les hospitalisations, les 4 vaccins confèrent une protection là, supérieure à 90%. Le Delta, en rouge vin, alors on voit que le Delta Pfizer, c'est très bon, Moderna, c'est très bon. AstraZeneca semble un peu plus faible envers les infections par le Delta, mais protège quand même bien contre les hospitalisations avec le Delta. La dernière colonne, c'est si, par exemple, on a eu l'AstraZeneca en premier et un des 2 autres, Pfizer ou Moderna après, et vous pouvez voir que ça améliore quand même beaucoup. On rejoint les taux de protection atteints avec Pfizer seul ou Moderna seul. Alors, ce sont des données très intéressantes qui, quand même, nous rassurent sur la protection à long terme et contre le Delta. Diapo suivante. What's new? Est-ce qu'on a besoin d'une 3e dose? Alors, les données que je viens de vous présenter sembleraient dire qu'on n'a pas besoin de 3e dose, n'est-ce pas? Ben, on a déjà recommandé une 3e dose chez les immunocompromis. On a déjà recommandé une 3e dose chez les gens en dialyse. Et je vous ai parlé des éclosions en CHSLD et RPA. On sait que les personnes très, très âgées ont une diminution plus rapide des anticorps, ainsi qu'une réponse initiale moins forte que monsieur, madame, tout le monde. Notamment à Montréal, vous le voyez ici, là, en fait, au Québec, je vous ai parlé qu'il y en avait 19 à Montréal, mais dans tout le Québec, il y a 38 éclosions dans des RPA, 13 dans des CHSLD. Et si on regarde à Montréal, 14 des 19 cas sont survenus chez des gens pleinement vaccinés. Il y a eu 4 hospitalisations et un décès. Chez les RPA, 65 de 73 cas à Montréal pleinement vaccinés et 19 hospitalisations, aucun décès. Alors, c'est un petit peu sur cette base-là que le ministère a décidé cette semaine de donner une 3e dose 6 mois après la dernière dose chez tous les résidents de RPA et de soins de longue durée, vaccination qui va se faire dans le cadre de la vaccination influenza. Diapo suivante. Finalement, qu'est-ce qu'il y a de nouveau? Quelque chose qui est passé sous le radar, mais qui a fait les nouvelles récemment. En fait, ça, c'est pas passé sur le radar, mais la vaccination des enfants. Des données de Pfizer qui ont été soumises au FDA pour approbation. Et il semblerait que les enfants, près de 2300 enfants, répondent bien au vaccin en termes de production d'anticorps, avec une dose qui est 2 à 3 fois inférieure à ce qu'on donne aux adultes. Et là, les données vont être analysées, évidemment. Dans ma tête, il n'y a pas de doute que le vaccin va être très efficace pour prévenir la COVID, mais il faut s'assurer que le vaccin va être sécuritaire, qu'il n'y aura pas d'effets secondaires. Et j'ai bon espoir que la dose réduite va en effet mener à moins d'effets secondaires. Diapo suivante. 3e nouvelle, alors ça, c'est la chose que je trouvais qui avait passé sous le radar. Si on se souvenait que les traitements antiviraux ont eu un succès mitigé au début dans les études, il y a une nouvelle antivirale orale qui s'appelle le molnupiravir, qui est présentement en phase 2 et en phase 3, et quelque chose qui a été publié cet été où le virus sur 200 patients semblait quand même inhiber la croissance du virus de façon très significative chez les volontaires. Alors, il y a des études en cours de phase 3 actuellement pour voir si ça diminue la morbidité, les hospitalisations et la mortalité. Alors, il y a quand même de l'espoir à ce niveau-là pour peut-être un antiviral oral. Ceci dit, mon impression, c'est que ces agents-là, s'ils sont pour être efficaces, il va falloir les débuter très, très tôt dans la maladie. On sait qu'avec l'herpès, avec l'influenza et la plupart des traitements antiviraux, ils sont efficaces si on commence dans les 48 premières heures de la maladie. Et l'autre aspect où il pourrait être utile, c'est en prévention secondaire pour les gens qui sont exposés. Il y a également une étude en cours qui vise à traiter les contacts familiaux de cas pour voir si ça prévient la survenue de la maladie. Diapo suivante. Les questions qui restent, combien de temps l'immunité durera-t-elle? Oui, les anticorps diminuent avec le temps. Je vous ai déjà dit qu'on a le meilleur intervalle au niveau vaccin au Québec. L'immunité naturelle, on voit que ça dure possiblement jusqu'à 12 mois encore. Et que de vacciner les gens qui ont déjà eu la maladie 6 mois après, ça induit une bonne réponse de vaccin. Les effets secondaires à long terme sont toujours une question qu'on suit de façon très active. Pour l'instant, tout semble relativement clair, mais vous comprendrez que c'est suivi à la loupe. Et on n'est toujours pas à l'abri d'un échappement immunitaire du virus avec un nouveau variant. Sous haute surveillance, pour les gens qui sont en pédiatrie, vous avez sans doute su que présentement, le Children et le Saint-Justine sont surchargés de cas de RSV. 600 cas la semaine dernière au Québec. C'est environ le quart de ce qu'on voit de COVID. Et ça, c'est avec une stratégie de dépistage très limitée. Vaccination, nos travailleurs de la santé. Alors, ma diapo n'est pas à jour, mais Dr. Feller vous a dit qu'on est rendu à 16 000 vaccins donnés, presque 14 000 2 doses. Bravo. On atteint des taux de couverture de 95 % chez les soins infirmiers, 87 % personnel paratechnique, 88 % de bureaux, techniciens, professionnels de la santé, 94 %. Ce sont tous vraiment des chiffres que I would call stellar. Mais il n'y a pas seulement les hôpitaux. Dans les cégeps, les données de cette semaine, 88 % vaccinés. École secondaire à Montréal, 78 %. Université, 89 %. On parle souvent des non-vaccinés, mais chapeau à tout le monde qui s'est vacciné. Je pense que dans le monde, on doit avoir un des taux de vaccination les plus élevés de la population en général. Je pense qu'il y a un petit groupe qu'on n'a pas assez reconnu, la santé publique au Québec. C'est vraiment incroyable, tous les choix éclairés, les décisions scientifiques qu'ils ont prises et le fait que le ministère a écouté la santé publique, contrairement à d'autres endroits dans le monde ou en province. Vraiment, on a bénéficié grandement aujourd'hui pour un retour à une vie des plus normales. Et sur ce, je vous remercie.
Merci beaucoup, Dr. Frenette. On va maintenant laisser la parole à nos collègues qui vont présenter sur la vaccination obligatoire. Je sais que c'est un sujet qui est très attendu par beaucoup de gens. So I'll ask Mrs. Dubé and Mrs. Lefebvre to make their presentation on the vaccination of healthcare workers.
Merci. Evelyne? Merci. Alors, on parle ici, je vais essayer de répondre à certaines questions en même temps que j'ai pu lire jusqu'à maintenant. On parle ici d'une décision ministérielle, d'un décret ministériel que le CUSM a l'obligation d'appliquer. Pour le moment, c'est un décret ministériel, vous avez entendu parler dans les médias. Nous, on a reçu copie vendredi soir passé des différentes règles qui devaient s'appliquer. On a d'ailleurs dû faire certains ajustements que je vais vous présenter. Donc, pour le moment, c'est de la vaccination obligatoire pour un temps qui est indéterminé. Même nos nouvelles embauches, on devra embaucher des gens qui sont complètement vaccinés pour qu'ils puissent commencer à travailler. Qui est concerné? On parle maintenant de nos travailleurs qui sont en contact avec des patients possibles, présumés ou directs, ainsi que ce que moi j'appelle des contacts de contact. Alors, c'est le personnel administratif. Finalement, dans tous nos bâtiments où du personnel clinique est amené régulièrement à travailler ou peut être amené à circuler, automatiquement, les personnes qui travaillent dans ces installations-là doivent être vaccinées. De notre côté, au CUSM, tout notre personnel administratif doit donc maintenant être vacciné. Qu'est-ce qu'on a fait jusqu'à maintenant? Ça fait plusieurs semaines qu'il y a des listes parce que l'information était transmise par plusieurs d'entre vous au bureau de santé. Alors, c'était des listes qui étaient envoyées aux gestionnaires pour s'assurer de qui était vacciné, qui n'était pas vacciné et faire un suivi auprès des personnes qui étaient non vaccinées pour savoir si le statut demeurait le même. Donc, on a commencé par vérifier si on avait l'information adéquate sur le statut et maintenant, on est plus dans s'assurer de savoir quelle est la décision finale de nos employés. J'ai vu en première question tout à l'heure que certains semblaient dire qu'ils ne se sentaient pas autorisés de discuter avec leurs collègues du fait qu'ils soient ou non vaccinés. Si vous avez des discussions respectueuses entre collègues de travail sur ce sujet-là, vous pouvez le faire. Ce n'est pas un interdit, non. Donc, il y a des messages textes qui ont été transmis aux gens selon les fichiers qu'on avait qui étaient non vaccinés pour rappeler l'importance et pour rappeler de nous faire parvenir l'information. Et il y a des lettres également qui ont été transmises. Donc, à partir du 15 octobre, les gens qui ne seront pas complètement immunisés. Donc, qu'est-ce que ça veut dire? C'est 2 doses et que 7 jours soient passés entre la dernière dose et le 15 octobre. Donc, ces gens-là ne pourront pas être à l'horaire et seront suspendus. Donc, seront en absence autorisée non rémunérée à la maison jusqu'à ce qu'ils soient complètement vaccinés ou encore que l'arrêté ministériel cesse. On reçoit beaucoup de questions sur la réassignation. Donc, exemple, je suis une agente administrative qui travaille sur une unité de soins, je refuse de me faire vacciner pour toutes sortes de raisons. Est-ce que je peux être réassignée dans les services administratifs? La réponse est non, parce que les employés des services administratifs doivent également être vaccinés. Donc, la seule option qui demeure, c'est de regarder une option possible de télétravail dans votre titre d'emploi avec votre gestionnaire, mais on comprend qu'il s'agira de situations exceptionnelles, vraiment très exceptionnelles, parce que les gens qui avaient la possibilité d'être en télétravail, pour la plupart d'entre eux, le sont déjà. On continue, s'il vous plaît, Evelyne. Merci. Plusieurs aussi souhaitent invoquer des restrictions médicales. Voici donc la démarche. Vous devez aller voir votre médecin qui doit remplir un formulaire qu'il connaît. Et lorsque c'est confirmé, vous devez vous rendre dans un centre de vaccination qui pourront alors valider les éléments et vous obtiendrez un code QR et vous nous ferez parvenir la preuve de votre code QR. Donc, ce n'est pas le service de santé du CUSM qui va décider si effectivement vous pouvez être exonéré de la vaccination. Pour les gens qui seront en absence autorisée sans solde, simplement vous rappeler que vous aurez droit au maintien de vos assurances pour un délai de 28 jours. Passé ce délai, ce sera votre décision et vous devrez payer les primes au complet parce que l'employeur en paie une partie. Il n'y aura pas de contribution à votre plan de pension, donc à votre régime de retraite, excusez-moi, je fais de l'anglais au français. Et il n'y aura pas d'accumulation d'ancienneté, d'expérience, de toutes les sortes de vacances mobiles, etc. Et l'autre élément, je vais le passer. Merci. Evelyne? Patricia, je te laisse la parole pour celle-ci.
Oui, bonjour. Théoriquement, mon vidéo est ouvert, mais je vois qu'on voit Caroline, mais c'est correct. Alors, bonjour tout le monde. Good afternoon, everyone. So we're being asked how are we going to triage or filter people at the main entry points. So as of October 15, what we're proposing, considering that we have a very high vaccination rate, that people who are not adequately vaccinated are not going to be scheduled to work. We are proposing that there will be no verification for any MUHC card holder because only adequately protected people will be allowed to work. So everyone who shows their MUHC ID card will be able to go through any access and go to their work and their offices, to their units. We are still in development, and I'll come back to the exceptions. Still in development, we are looking at the family presence policy presently, and it will be ready in the coming days. The Prévention Contrôle des Infections guidelines are also in development, and we are going to be looking at some specificities for the Montreal Children's Hospital. What are the exceptions that people can come in when we talk about visitors, patients, and families? So anyone who's coming with a patient that's under 14 years old, if the person is not adequately vaccinated, can actually accompany that patient. There will be, like we had in other ways, the end-of-life circumstances that will allow non-adequately protected to visit the loved ones during labor and delivery as well. If someone is accompanying a patient who doesn't have the capacity to consent to care, or if that patient requires assistance that we cannot provide by the hospital, these will be the only exceptions that will be approved. For everyone else that will be coming through our door, and we're not talking about patients because patients are coming for essential services, we will need to have the vaccination proof, so the code QR and a photo ID, and these people will be validated. The code QR will be checked at the entrances. So there will be some additional information, but these are the guiding principles that will be applied as of October 15. So that ends our presentations for Caroline and I. Thank you. Bon après-midi tout le monde.
Merci beaucoup à tous. Thank you, everybody. Nous avons beaucoup de temps pour une période de questions-réponses et c'est merveilleux. J'imagine que nous avons plusieurs questions. Rachel, are you ready to start firing questions?
Yes, I am. First question is, why are we going to a 21 days interval if it is not optimal, as mentioned by Dr. Frenette? And then another question about that is, should healthcare workers who are vaccinated at 3-week dosing schedule receive a third dose?
Dr. Frenette.
So I know if I was going to say that a question would come. Well, you know, that's the consequence of being late. You got door is closing. The door was not made by us. It was decided by the ministry. For now, there's no third dose prescribed for healthcare workers, which doesn't mean that in the future there won't be, and we'll have to see what happens with time.
Merci, Rachel.
When do you expect to see increased infections in healthcare workers after fully vaccinated due to waning response?
Dr. Frenette, you're up again.
Yeah, we don't know. I mean, for now, we have not seen increased infection in the healthcare workers due to waning vaccine. But remember, we're only 6 months out for a second dose for most of us, or less than that. So I think that's where the surveillance and the epidemiologic data, to follow month by month will let us know.
Even if there is waning immunity, would you have any speculation on the severity of a subsequent COVID-19 infection in a properly vaccinated healthcare worker?
Well, the hypothesis, and as I've shown you, is that even if you have cases, they tend to be benign and lead to less hospitalization and certainly less ICU care. And so that's maybe something that we'll have to learn to live with. If it only behaves as a benign cold, maybe we might not choose to give an extra vaccine. So again, we'll have to wait for the data. Jury is still out.
Thank you, Rachel.
When I first started, vaccinations were obligated, and if some were missing, we needed to get them updated by the Health and Safety Department. Why about 2 years ago, this rule was removed and no longer obligated?
Dr. Frenette or Madame Dubé?
Well,
Yes.
I can tell you what, I can tell you what I think someone may refer to. This may be someone that's relatively young. So vaccination was required very often, for example, hepatitis B as a condition for employment. But it was never mandatory before. And so it was an issue, I have to tell you, with influenza, for example, it was never mandatory. And so I think it was more a condition of employment than mandatory 2 years ago.
Thank you. Madame Dubé, on ajoute ou ça va? Merci beaucoup, Rachel.
Healthcare worker chooses to travel outside of Canada and is fully vaccinated. Can they return to work immediately upon their return?
Dr. Frenette.
Yes, they can. As
Rachel?
long as it's a Canada-approved vaccine.
Thanks, Rachel.
How will the MUHC follow up on non-vaccinated administrative agents if all we need to show is our ID card?
Well, go ahead, Madame Lefebvre. Oui.
We will be provided with a list of employee, everyone who's not vaccinated, because I've seen comments. It does include the research institute. It includes everyone who comes through our door. We will get list of unvaccinated people, and we will deactivate, all the ID cards will be deactivated.
Merci. Rachel?
Can a person accompany a patient under 14 years old but can be unvaccinated? Parents visit a hospitalized child under 14.
Hospitalized child has the same accompanying person rule, so an unvaccinated parent is not forbidden to accompany an admitted child. And unless Patricia has other news than that, that's pretty much my understanding of it.
That is correct.
Thank you. Rachel? Sorry, I'll just interrupt you by adding that we still must take advantage upon the discovery of any unvaccinated parent of an admitted child to encourage them to get vaccinated. And up until some date in October that escapes my mind, we're still able to even send them without an appointment to the vaccination center at the Glen to at least start that process for any parent who we might have been able to convince. All right, sorry for the interruption, Rachel.
That's okay. Can you comment on the situation for non-vaccinated physicians who are not employees?
Maybe I'll take a stab at that in Eva Sidorowitz's absence. We have gone through the list of all PEM actif, PEM associé, permis temporaire, etc. And we're happy to see that there is so few that I think we're counting them on a couple of hands for the entire MUHC, but the same rule applies to physicians. Their privileges are to be suspended, and their license will be suspended by the Collège des Médecins as well. It's not just a question of physicians working in public sector hospitals. It's all physicians, even in private offices, billing RAMQ. They will be subjected to the same rules as per the Collège des Médecins.
Peut-être ajouter, Robert, si tu permets, Patricia pourrait peut-être aussi jump in, mais c'est un acte dérogatoire aussi pour tous les professionnels de la santé qui sera rapporté à leur ordre professionnel. Je ne sais pas, Patricia, si tu veux ajouter.
Oui, effectivement, tous les autres professionnels avec code de déontologie, ce sera un acte dérogatoire de ne pas être vacciné. Et ce sera rapporté. Les autres professionnels sont tenus de se faire un suivi.
Thank you. Rachel?
What about Glen restaurant employees? Will they need to be double vaccinated as they are in contact with employees and patients?
My understanding is yes. Patricia, yeah, the answer is yes. Because it's access to a public sector healthcare institution. And so all of the contractors and suppliers, et cetera, will be subjected to exactly the same rules in order to gain access to the premises.
Okay. How will security at the entrances verify who has an appointment and who doesn't?
Patricia.
At this point, because the patients will, usually they have confirmation of appointments. So anything that's essential services, we will we will ask the question and rely on the person to answer adequately to the question, like we've been doing at this time. People are coming to our entrances and they're telling us they have an appointment and we let them through. I have to add that we will be doing the random controls, 24 hours, 7 days a week, 24 hours, and we will make sure that we also are checking the vaccinated status. So this, we have a plan for random controls.
Thank you. Rachel?
That's good. I will add it to the poster at the beginning so people will know. Any concerns about getting the flu vaccine and the COVID vaccine? Recommendations for interval delays between vaccines?
Dr. Frenette. Dr. Frenette, you're on mute.
Sorry. There's a couple of papers showing that if you get it at the same time, there is no interference, and I think that's what's planned in the CHSLD and RPA to give both the third dose and the flu vaccination at the same time. Otherwise, in terms of distance, time between the two doses, the same rules as any other vaccines would apply.
Thank you. Rachel?
Are infection control measures expected to change given that more people stay indoors and for longer in the winter?
Good question. So, as much as this summer, the big question is what's going to be the impact of déconfinement. The question is September is what's going to be the impact of schools. The question of the fall is going to be what's going to be the impact of everyone moving in, and I can't tell you, to be honest. There's no question that the high vaccination rate has an incredible impact. I didn't go into much details, but as much as there are many schools outbreak, the number of cases per school is very, very small. And even if you have a child that brings COVID home, if the two parents are vaccinated, there's 90% chance that it will stop there. I think the schools are living now what we saw in last winter is the incredible impact of collective immunity through vaccination.
I can add that from the Montreal Children's point of view, we're having an extremely bad winter season right now, and it's not even winter yet, but it's not COVID directly. It's the usual winter viruses that are coming back with a vengeance. Rachel?
Pour les employés qui sont doublement vaccinés, quand est-ce qu'ils pourront enlever leur masque au travail?
Pas jusqu'à nouvel ordre, unless Charles voudrait ajouter quelque chose.
Well, Dr. Arruda yesterday said it was a fantasme to remove mask. Now, depending if you call fantasme is something you never realize, you keep dreaming of. I don't know, to be honest, I think we're in to keep the mask, through this winter season. Because the previous question is that we do not know how long the immunity will last. We still have this 10% failure rate. The one thing I didn't specify, but you should note that despite having 82 healthcare workers coming in down with COVID and about half of them working while they were sick, we've had no nosocomial case. And I think largely because of the mask. So we've been protected our patients really well in all our institutions.
Et donc, cette politique risque de protéger tous nos collègues et patients de toutes les autres bébites respiratoires, laissons de côté la COVID-19, n'est-ce pas?
As well.
Oui, merci. Rachel?
Will the security at 5252 de Maisonneuve enforce the mandate and be checking vaccine codes at the door?
Madame Lefebvre?
All the entrances will be covered, and we'll be checking the vaccine code for when it applies. I've seen some questions about the contractors, the suppliers, and everyone else. As they do not hold a MUHC card, they will be checked at the entrance. And yes, we sent letters to all the suppliers and all the companies that we work with to inform them of that policy. I also need to, I know that Caroline said it, but we will apply the same rules at all our buildings. So it includes 5100, 2155, 5252, 8300 Descaries as well. So they will be exactly the same procedures at all our sites.
Merci. Rachel?
Switching gears a bit, what are the characteristics of the fully vaccinated persons that are hospitalized?
So, yeah, I didn't mention that, but the case we've had, they were severely immunocompromised patients, renal transplants, liver transplants, patients with chemotherapy for cancer, hematological cancers. And so really people who generally speaking do not have a normal immune system. I have to say that last time we looked, I think 10 out of the 10 cases in the ICU were all non-vaccinated. But we had one or two transplant patients admitted in the ICU.
Thank you. Rachel?
I would like to understand better if there's insight on rapid tests being available for individuals for themselves, like in the UK.
Rapid testing. Dr. Fournette.
So a good question. And so people get confused about rapid tests. So remember, there are two types of rapid tests. There's the rapid test that is based on PCR and RNA, which is about just as good as the regular test. Unfortunately, that test is not available at the MUHC, but it is available in other centres de dépistage. And then there's the rapid antigenic tests, the one you hear about in schools, which is just as rapid, but is really, really, really poor. It's like 30–40% poorer in terms of sensitivity. And, so a negative test does not rule out the disease. And so it's probably good in a school context where you have a whole classroom and you have 10 kids are sick. Well, the test will pick up 6 out of the 10 and you'll know you have an outbreak. But on a one-to-one basis, it's not good enough. And so if you were to have a rapid test, I would just make sure it's a PCR test, i.e. the ID now.
Thank you. Rachel?
The directive says that employees with the COVID in the last 6 months are considered adequately protected. Will this individual need a dose or 2 of the vaccine? And if so, when?
So for now, we say 1 dose and 6 months after your first COVID test.
Thank you. Rachel?
For a worker who is not exempt according to the ingredient allergy criteria, but had an anaphylactic reaction for other vaccination and is reluctant, do we have any resources that they can contact to help them evaluate their situation and arrange appropriate support at the time of vaccination?
So we're really, really lucky at the MUHC. Dr. Tsoukas has organized a clinic specifically for those cases. They will test every component of the vaccine to make sure that you don't react. And they even have a vaccine, desensitization protocol in case. And so if this is your case, please take advantage of the fact that we offer that service here at the MUHC.
I can add that the Montreal Children's Allergy Clinic is similarly set up for referrals of for patients, young patients where there may be that concern as well. Rachel?
Are there projections on healthcare service delivery impacts at the MUHC due to mandatory vaccination?
The answer is yes, and we are studying them very carefully in order to make the contingency plans to have the least impact possible on patient care. Those are ongoing as adjustments are made, and I'm sure there will be more announcements coming after all the right people are working on that, and the Centre de Mesures d'Urgence has had a chance to study them. I don't know if Caroline or Patricia want to add anything beyond that sort of generic answer, but rest assured, we've seen this coming and we are working very hard on it. Rachel?
For all those who have their ID disactivated, does their access to emails and folders get disactivated as well?
Caroline, would you have that? Or Patricia, I see you took off your mic, so go ahead.
It is in discussion. We haven't decided yet. At this time, we for sure are deactivating the ID cards only at this time.
Thanks, Rachel.
I've seen a lot of babies and kids coming to visit on the adult side, some even grandchildren. Since they are the biggest carriers currently, shouldn't we address and limit these visits?
They may be significant. I'm not sure they're the biggest, but Patricia, do you have anything to say about the visiting policies of unvaccinated young children on the adult side?
No, this is still, the group is still meeting, so we probably will have something by the end of next week. They'll take all those questions to the group.
Rachel?
Changing tax, what changed recently to reduce wave 4? Waves 1 and 3 were stopped by summer, wave 2 by aggressive confining, but what stopped wave 4?
Dr. Frenette.
Well, I would correct that I think that wave 3 was at least partially stopped by vaccination, but I think you can't be reductionist and point to a single measures. I think it's a combination of measure. Certainly, as much as we had double vaccinated earlier, the population only got their second dose this summer. So I think that has something to do. I think the mask in the schools also had an incredible, prevention effect. As you know, this was a controversial measure at the beginning, but they decided to put the mask back in the schools. And I think all the other, public health measures, limiting the number of people in social events, the distancing, the mandatory passports for events that a lot of people have implemented. I don't know if you went to the jazz festival, but you had to be vaccinated. Or if you're going to see the Canadians. So I think all those measures all together contribute to really limiting the spread. In particular in Quebec. I mean, if we compare what we have compared to out west, you know, and we know that out west, the deconfinement in Alberta was way earlier and much more free than what we had.
Il est maintenant 13 heures. J'aimerais remercier tous nos présentateurs pour vos contributions excellentes, mais aussi pour toutes ces excellentes questions. J'imagine qu'on aura une chance très bientôt pour se réunir à nouveau parce qu'il y a toujours des questions. C'est toujours en évolution. Merci à tous et bon week-end.